Welcome to PharmaDocs with your host, myself, Dr. Jay Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. Well, hello there, John. How are you? Long time no see.
Yes. Hello, Jay. Happy New Year to you
Happy
and
New Year.
our guests join us today. How are you doing, my friend?
Good. Lot happened in the last since our last episode. Kind of took a hiatus there for a while, but now we're back and back
and loaded. Lots of great information, Jay, and a lot of great exciting news to share with our audience.
That's for sure. That's for sure. So we're going to do things a little differently than we did before. We're actually going to, we had a lot of messages from our emails and instant messaging from some of the people watching saying, can you write down the names of the medications you're talking about? Because it's, you're saying them and it's hard to catch all that. So what we're doing now is we have slides.
Yes.
And the slides will give you some insight into what we are talking about. And so that way you'll be able to write down, kind of jog down your notes, and you'll know the drugs that we're talking about. So welcome, January 13th. It's a brand new year, and we're really excited to have all of you with us. This is the first of many, what we're calling Pharma Friday, staying with the pharma theme. And it's going to be the second Friday of each month at 2 p.m. Pacific, which is 5 p.m. Eastern time. And it will be, for right now, it's going to be streaming on YouTube and LinkedIn and I think and Facebook. But we will soon have another venue that it will go through. Dental Learning LLC has become our partner in PharmaDocs, and so we'll be using their platform in order to stream our webinars from probably starting next month, most likely.
That's correct, Jay. And like you said, dentallearning.net is our new educational partner. We're very excited because that's some of the exciting news we have to share about this, because they just do a fabulous job in the dental profession.
Yeah, they do a lot of online CE.
Yes.
And I think John and I both done some CE with them. Really top-notch company, and actually run by people who've been in dental education for a long, long time. I know the guys who run it, and I think I've known one of them for 15 years, one other one for at least 20. So we're all in good hands.
Yes, we are.
So we'll welcome you all to the first PharmaDen of 2023 on Pharma Friday. And we are going to start things off by talking about new drug approvals. And obviously we can't go through all 84 drugs that were approved in 2022. That's just a little too many to go through. But as you can see, there are an average, let's say 80 to 100 new drug approvals every year approved by the FDA in the US. And so just as an example, if you graduated dental school in 2016, that's about 550 new drugs that have come out or been approved since you graduated. So there's a lot to know about, because these drugs are going to be taken by patients that are coming into your office on a daily basis. And you've got to know, is this a drug that may affect my treatment of this patient? Is something that I do or prescribe for this patient going to affect the basically the efficacy of the drug they're taking? Is it going to give them a toxic level of the drug? How am I going to have to modify my treatment because they're on this medication? So there are a lot of things that you need to know. And a lot of times you need to contact the patient's physician, whoever that might be, if it's a cardiologist or oncologist, whoever has them on the medications that you're concerned about, so you can consult and discuss together what you need for the patient, what your plans are, and they can discuss with you what their needs are as far as keeping the patient safe during the procedure. Because again, keep in mind that physicians don't know anything about dentistry. They're taught that I think they're taught that there are 32 teeth. I'm not quite sure about that. But that's about the extent of it. The
Yes.
most education I got in oral surgery or dentistry in medical school was in the ENT rotation, when at the lecture, the professor said, the area between the lips and the uvula, that's for the dentist. Don't worry about it. So that's
So
how much
Jay,
most physicians know about dentistry.
So Jay, just to focus on what you just said, if our audience is looking at those 6 years right there, you're looking at 592 drugs that have come out in the last 6 years. And are they going to affect
Did you just add that up in your head? Just right now?
I
Wow.
did.
Impressive.
And thank you though, Jay. But anyway, are these medications that came out, are they going to affect the way you treat your patients? Absolutely.
Yeah.
And you must know how to treat them, because if we have an adverse drug reaction, this could wind up with a potential life-threatening medical emergency in your office.
Exactly.
All right. So how does one, Jay, keep up with all of this?
Well, there's this webcast called PharmaDocs with these two guys that are actually in practice treating patients every day.
Yes.
And I heard they're gonna kind of talk you through. They're gonna keep you up to date with these medications by a once a month webinar. And I guess I actually went over that already. So we're going to be going over these things. What do you need to know before you treat the patient? Whether you need to get a medical consult, about antibiotics, and we're going to discuss some of these. And so we've selected, was that 9 drugs? 9 drugs.
That's correct.
For 2022 that have dental implications. And these are Finetra, Rolvedon, Stimufend, Reluco, Monjero, Zonacide, Camzios, Qvivic, and Rebiota. And I don't know.
Gotta love those names.
I don't know where they come up with these names.
Yeah. But Jay, I want to remind the audience.
They don't exactly roll off the tongue.
No. And we're giving you the brand name right there. The patient that comes in might write down their very best, the generic name.
Yeah. Yeah.
And so I just want to ask you watching us to right now, when you look at those, like, okay, what do those drugs do?
Yeah. And, if a patient comes into your office taking a drug and you're not familiar with the drug, just don't say, oh, okay. Look it up, see what it is, find out what you need to know about that drug, because what you don't know can hurt you and the patient.
Or Jay, send your dental assistant in there ahead of time and let them go through a brief health history with the patient, including medication history too. Bring that back out and say, okay, here's these drugs, doctor. And then you should be able to pick up the ones that, I don't recognize that. Well, that's time to research that drug right quick. Yeah,
that's how we do it in the office.
That's correct. Same here.
So I know everything about the patient before I walk into the room. Maybe go over some of the things in their medical history, just verbally with them, just to clarify some things. And then we kind of get into the business of examining the patient and discussing treatment.
Well, it just makes you look better and more competent in front of your patients as well, too, Jay.
Yeah. Yeah. I mean, you can't possibly know all, was it, what did you say? 590 new drugs?
592 new drugs in the last 6 years.
Yeah. You can't possibly know them all.
No.
And so you want to have
you and I can't. I mean, but we're going to do everything we can to educate our fellow dentists, because like you said, we're in the trenches with you as well, too.
Yeah.
All right.
We're
going to cover a lot of topics. That's exactly right.
All right. So the first drugs that we're going to talk about, these 4 drugs are all for treatment of neutropenia. And so they're Filentra, which was approved in May 26th of this year.
Yes.
Rolvedon, which was approved in September. Stimufend, which was also approved in September. And Reluco, which was approved in February of this year.
Right. And of course, Jay, what you're leading right on into Reluca right there. It's a treatment for all of these drugs are neutropenia associated with chemotherapy. All
Yeah.
right.
Yeah.
And Reluca is a recombinant human granulocyte colony stimulating factor. It's
Mhm.
similar to Neupogen. All right.
Yeah.
And
Yeah.
Neupogen is an older drug,
Yeah.
but is it all indicated for the treatment
Pegfilgrastim
of
that's been around since 2002.
yes. And oh, by the way, for our audience, whenever you see the four letters after like Phil Graston, AYOW, that's just a irrelevant four letters that the FDA put on there to help distinguish
Yeah.
that drug.
Yeah.
All right.
So basically what that means is this drug is nothing really earth shattering. It's a new drug, but it's biosimilar to another drug that's already been established. And biosimilar basically means it's essentially the same drug,
Yes.
but at some unimportant areas in the molecule, they've made some small changes that don't affect the drug at all, so that they can get in under the FDA approval of the previous drug, and the FDA just assigns 4 random letters to go at the end.
Correct.
So
And,
that's what these are. And so
you're go,
all these 4 drugs we're going to talk about are all biosimilar drugs
yes.
to drugs that have been on the market.
And you're going to see this in other classes like immunosuppressants. You're going to see this all this year when we go through all these various medications.
Yeah, yeah. And so the Reluco is a GCSF, that's a granulocyte colony stimulating factor stimulant or agonist. And so the difference and some of the others are just leukocyte growth factors. Right. And the difference between the two is when we're talking about granulocyte, well, actually, when we're talking about a leukocyte growth factor, that's essentially all white blood cells. When we talk about granulocytes, we're referring to only those cells which are granular, like neutrophils and eosinophils and basophils and mast cells, as opposed to the agranular cells like monocytes and T and B cells. So a leukocyte growth factor only increases the production, stimulates the bone marrow to produce all white blood cells, whereas a GCSF only stimulates the bone marrow to increase production of granulocytes.
So the bottom line, Jay, as we start going through these drugs, these 4 drugs do one primary thing. They boost neutrophil production.
Yeah.
All right. So the average in the healthy person like you and I, Jay, our neutrophil count would be anywhere from 2,500 to 6,000 neutrophils per microliter.
Right.
All right.
Right.
But go ahead.
I was going to say, and the way that you calculate the number of neutrophils is on the CBC, you'll have a differential blood count, and it'll tell you the percentage of the various types of white blood cells.
Yes.
Right? So the the leukocyte, I mean the all the different granulocytes, like the neutrophils, eosinophils, etc. And so what you do is you take the total number of white blood cells, which generally is above 5,000. 5 to 10,000 in that range, and you multiply it by the percent that are that particular cell. So let's say the CBC shows 25% neutrophils, then the total, basically the neutrophil count, the absolute neutrophil count would be 2,500, or would be 250. Sorry.
All right, next drug.
Okay, so the next drug is Filnetra, which again, as you can see, is a biosimilar drug, biosimilar to Neulasta, which is pegfilgrastim. And again, this is another drug that's used for treatment of neutropenia, and neutropenia is defined as less than, I'm sorry, I said it should have been 2,500 neutrophils if we're 25%. If you have a neutrophil count below 1,000, that's considered neutropenia.
Yes.
And so that's where these drugs are used. So if the absolute neutrophil count is below 1,000, then that's defined as neutropenia, and that's where these drugs come into effect. So another one is Stimufend, and that was one that was approved in September. And basically the same thing. It's a biosimilar to Neulasta, and does exactly the same thing. It stimulates the leukocyte. Actually, it's a leukocyte growth factor stimulant, again like Neupogen, and so it increases the production by the bone marrow of all white blood cells. And then the fourth one is Rolvedon, which is a another biosimilar, and this one is a GCSF, so granulocyte granulocyte colony stimulating factor. So it only increases the number of granulocytes, and they're all used basically for chemotherapy neutropenia. But there are other causes of neutropenia. Chemotherapy or radiation induced is really the most common, but there are
Correct.
a number of other factors that can also cause neutropenia, like certain medications, like even penicillin. One of
Yes.
the big culprits is vancomycin, which is used for really severe infections, or different types of infections like Epstein-Barr, hepatitis, RSV, CMV, HIV, Epstein-Barr. Those all can suppress the bone marrow and result in neutropenia, as well as some autoimmune disorders like rheumatoid arthritis and lupus can cause a neutropenia. And of course, bone marrow diseases like aplastic anemia and acute leukemia.
Now, Jay, some of the signs and symptoms associated with neutropenia that we'll see in our patients that come to the office, because we are going to see these patients. We are going to see people undergoing chemotherapy.
Yeah,
they're going
absolutely.
to need dental treatment, or they may need oral surgery.
Yeah, exactly.
And we're going to have to be prepared to treat that patient to the very best of our ability, alongside with their either oncologist or radiation oncologist or hematologist, so that we can keep these patients from having an infection as well too. But some of the signs and symptoms we're going to see are fever or bruises, sores on the skin, mouth sores, sinus infections. They could even be tachycardic as well too, coughing, wheezing.
And these oral lesions, because you may see them in your practice in a patient that's neutropenic, they're basically ulcerations, and some of them can actually look like huge areas of necrosis of tissue too.
Yes.
So if you see something like that, and you see multiple lesions like this, one of the things you want to suspect is this patient may be neutropenic. So you want to refer them to their primary care physician before you treat them to see what's going on. Or if
also you're going to want to find out too, Jay, like we said, we already know the normal count on that. And then anything under 1,000, they're going to be prone to infections. You're going to need antibiotic coverage. You also might need chlorhexidine, but you also got to be aware of the sores in their mouth. They may need some type of 1, 2, 3 mouth rinse or magic mouth rinse, whatever. It's all got so many different terminologies there that help make those ulcers in their mouth feel better as well too. And the other thing too, Jay, when dealing with the oncologist, we'll need to find out about the nadir, which is the lowest blood count, which usually occurs anywhere from 7 to 14 days after they've received their chemotherapy.
Exactly. So that's when you don't want to treat them.
No.
You want to optimize their white blood cell count, and that's usually in the few days before they go back for their next round of chemotherapy.
That's right. So a phone call is warranted to their oncologist or hematologist, so you're both on the same page, and we reduce our chance of infection for our patients.
Exactly. And and another thing to keep in mind is that when a patient has neutropenia, it's not always because of decreased production of white blood cells. It can also be due to destruction of white blood cells by various disorders, or it could be to sequestration of white blood cells, like in a diseased diseased spleen, for example.
Right. Great point right there as well.
Yeah. But most of the symptoms you're going to see are basically due to inability to fight infection and fatigue, et cetera. Okay, so let's move on to Mounjaro. Now, I kind of like that name.
Isn't that great?
Yeah. This sounds like a good drug. And in fact, I just read something about this drug today, that it may have a second indication that's going to be approved hopefully in the next year. So this is Mounjaro is a GLP-1, a glucagon-like peptide receptor agonist. And so what that does is it basically increases the secretion of insulin to reduce blood level. It also decreases the amount of gluconeogenesis by the liver so that it doesn't increase the amount of glucose in the blood. And the third thing that it does is it delays gastric emptying.
Yes.
It reduces gastric motility. And so some of the side effect of this drug is that by reducing gastric motility, patients who are diabetic patients who are taking this type of drug, a GLP-1 type drug, tend to have what we call early satiety. They don't have to eat a lot of food,
Right.
and they feel hungry, or I'm sorry, they feel satisfied.
Satisfied. They
satisfied
are
for a
not
long
hungry.
time. They're not hungry.
That's right.
And in fact, because of the delayed gastric emptying, they have a slower absorption of carbohydrates and other nutrients from the food that they're eating. So in effect, it
Loses weight.
It's like they end up losing weight. And so this is what this indication, that second indication, is for. Mounjaro and a couple other GLP-1 peptides are being looked at for approval by the FDA for weight loss. Right now, there's only one that is approved, and that's let's see, which is the one that's approved now?
Saxandra.
Ozempic.
And Ozempic.
Yeah.
Okay. So these are being off-label uses, Jay. People are getting these once a week or once a month injections to lose weight.
Yeah. Exactly.
And it's working.
Yeah.
It is working.
Yeah.
All right.
So when these types of medications are used for diabetes, they are a supplemental type of treatment. So this is not the only treatment alone for type 2 diabetes. Generally, it's used in conjunction with some of the other types of medications that are used for treating blood glucose. And the way that diabetes type 2 is diagnosed, of course, is from the patient being hyperglycemic. And the way that you can diagnose that is if a fasting blood sugar is greater than 126 or above, so greater than 125, or if it's just a random blood sugar, so non-fasting, if it's over 140 milligrams per deciliter. And so when the diagnosis is made, then of course the patient gets into treatment for their diabetes, and that's done if the patient has some of the symptoms of diabetes. Now there's type 1 and type 2 diabetes. Yeah,
that's right.
And so John, why don't you talk about the differences between type 1 and
well,
type 2?
With type 1 diabetes, Jay, we're going to see increased thirst, increased urination, weight loss in spite of an increased appetite.
And that's for type 1. So that's type 1. Both type 1 and type 2 have the characteristics polyuria, polydipsia, polyphagia. Yep. So you're eating a lot, peeing a lot, and eating a lot, peeing a lot, and not gaining any weight. Yeah,
that's right. And you're fatigued.
Yeah.
You could also have unexplained nausea, vomiting. But also with type 2 diabetes, very similar to that, men could have impotence as well too.
Yeah. Yeah. Because diabetes does affect peripheral. They get diabetic peripheral neuropathy, especially the feet, but also the genitourinary system. So that's one of the things that's checked for if a patient comes into their physician complaining of ED. They always check for diabetes. And generally, this is type 2. So type 1 is generally thought of as being, and type 1 is the generally insulin-dependent diabetes. And it's generally thought of onset in younger ages, like in before 10 years old or early teens. Whereas traditionally, type 2 diabetes has been more of adult onset. So it's not it's not an insulin production problem. It's a resistance to insulin that raises their blood sugar. So, and remember, the insulin is the hormone that gets sugar from the bloodstream into muscles, fat,
Into the cells. That's
into the
correct.
cells. And so if the insulin's not there to push those the sugar into the cells, the glucose into the cells, the blood level is going to be higher.
Right.
Okay.
And Jay, remember also with our diabetes, one thing we always want to ask our patients, whether it's type 1, type 2, hey, what is your A1C?
Mm-hmm.
That's because that's very important. And we're always shooting for numbers between 6 and 7. Okay.
Yeah.
All right.
Yeah. Any patient who's being treated for diabetes will know their A1C.
They will know their A1C. Mm-hmm. And the higher we go in A1C, the higher the risk for infection and non-healing.
Yeah.
Period.
So the A1C is a marker of long-term
glucose control.
Glucose control, exactly.
Right.
Whether the patient is taking their regimen the way they're supposed to, controlling their blood sugar. When you take the glucose at a single point in time, that doesn't tell you what the trend has been, whereas the A1C gives you a window into how effective they're treating themselves.
That's correct.
Yeah. So there are a lot of different medications that are used to treat diabetes. Some of the older ones are like metformin and glipizide. That's glucophage and glucotrol. And again, those are a lot of times used in conjunction with the GLP-1 to get better control. There are meglitinides like Prandin that increase insulin release. And so it's a different mechanism than like what glipizide does, which increases beta cells, stimulates the beta cells. And drugs like Avandia increases the sensitivity of the cells in muscle, fat, and liver to glucose. And then there are DPP4, so dipeptyl peptidase inhibitors that basically decrease glucose production in the liver. So they decrease the gluconeogenesis, which is the conversion of glycogen storage in the liver into glucose. So, and the drugs in that category are Januvia, which I've seen many patients on that, and Tradjenta. Okay. And then some of the other GLP-1 receptor agonists are, in addition to Mounjaro, are Trulicity and Ozempic.
Yeah.
And like we said, they're both Mounjaro and Ozempic are being used off-label for weight control. And I think there was I've seen some, on my Google News feed in the entertainment section, scandals of different celebrities who have been using these drugs to try to lose weight.
Yes. And Jay, what needs to be brought up also with these diabetic medications, in the last 10 years, we've had an explosion of just newer drugs coming onto the market, and that's going to continue.
Yeah.
Why?
Exactly.
Because about 35 million Americans, Jay, have diabetes.
Yeah.
Okay.
It's a large, and the number is increasing because people are getting fatter over the years.
Well, we're at about
our population is getting more obese.
Yeah, we're about at 40% obesity right now in America. Yeah. And Jay, when I lecture on medical emergencies, I have a term that I coin. Mm-hmm. I call it hyperdiabesity. So hypertension, diabetes, and obesity. You're going to see a lot of these.
They all go hand in hand.
They go hand in hand. And this is a medical red flag for you to be ready when you're treating these patients, because they're on multiple medications for hypertension, multiple medications for diabetes. And, with obesity, there are not any medications they're taking, except for these newer ones that you just mentioned. Yeah. But they're not doing anything about their body state. Yep,
exactly. And some of the other newer medications would be, and I'm sure you've heard of these, are Inocana, Farxiga, and Jardiance. Yes. They're advertised on TV and radio all the time. And these are SGLT2 inhibitors, which is a sodium glucose cotransporter 2. So I don't know why it's not SGCT2, but it's SGLT2. And what these do, these drugs inhibit renal reabsorption by affecting the sodium glucose exchange in the kidneys. And then, of course, there's, as a last resort, patients with type 2 diabetes are put on insulin in addition to the other drugs that are trying to increase the insulin sensitivity of their cells. They're also given insulin directly, which will help move sugar out of the bloodstream and into the cells, the muscle, fat, and liver cells where it needs to be.
Right. And you know, Jay, anybody with diabetes is going to be an ASA2 patient that walks into your
automatically.
office. Okay. Automatic.
No matter how well controlled they are. And
that's correct.
Now I learned in dental school that if you've got a well-controlled diabetic or a patient with type 2 diabetes, that they're at no higher risk of infection after a surgical procedure than the average person. And I found, and maybe John, you've found that also, is that that's absolutely not true. I've seen some rip-roaring infections in controlled type 2 diabetics even. And so you always want to consider that they are at higher risk of infection and generally cover them with antibiotics when you do a procedure that is anything beyond a simple, straightforward, non-surgical extraction.
I totally concur and agree with that statement there, Dr. Reznick.
Well, thank you. Thank you, Dr. Roberson.
Next drug.
Okay, so the next drug is Zonisade or zonisamide. And this is an oral suspension, and it is an anticonvulsant that is not used by itself, but as adjunctive therapy for the treatment of partial onset seizures in adults and kids over 18 years of age.
Right.
So not in young seizure patients or epilepsy patients. So, as we know, that seizure disorder, or actually, I'm sorry, having a seizure and a seizure disorder such as epilepsy are not the same thing.
Not the two totally different terms. That's correct.
Yeah. So you can have.
Go ahead. I'm sorry.
Oh, go ahead.
No, I was just going to say you can have a seizure. Yeah, you could have a seizure, but you don't have epilepsy. All right. You just got to be ruled out. Why did you have that seizure?
Right. So one of the things, especially in kids, is a high fever will cause seizures. Sometimes drugs will cause a seizure. And so, you have to determine if they just have one seizure, you got to determine why they had that single seizure. It's when they're having multiple seizures in a row, or 2-3 seizures in a day, or they're having seizures in their sleep, that they're given the diagnosis of a seizure disorder or epilepsy. And that has to be investigated to try to figure out what is causing this. Sometimes it's a brain lesion that's causing it.
Yes.
And so a CT or MRI may give some insight, but a lot of times it's just an irritable focus within the brain that keeps firing off abnormally. And that's what is causing these recurrent seizures. And something like a PET scan that looks at activity in the brain, or a SPECT scan that tries to find where the seizure is coming from using radioisotopes. Those are some of the techniques that are used to try to diagnose the seizure disorder.
Right. And Jay, right now in America, 3.5 million people have epilepsy. 3.5. All right. Now
that's a lot.
That's a lot. Now, every year, 150,000 newly diagnosed epilepsy cases. All right. Just in America.
Yeah.
All right. Jay, 1 million people have uncontrolled seizures.
Yeah.
All right. Now I want to help our audience even more, because we're huge into medical and sedation emergencies as well too. Yeah. Have any of you ever heard of SUDEP? SUDEP, sudden unexplained death in epilepsy. All right. So it's a rare complication, but it's a fact that it could still happen. All right. 1 adult in 1,000 die from this, Jay, every year in America. All right. So the risk of SUDEP increases if you have 3 or more tonic-clonic seizures. So when that patient's in your office, you need to ask them, how many seizures do you have a year? All right. And if they say, oh, I had about 5 or 6 this past year. All right. The light bulb should go off. Okay. I think I heard Roberson say something about this. All right.
Yeah.
Then Do you have seizures at night? Yes, I do. Well, now the risk is increased even more so. All right. Because
And these
this
are
means,
breakthrough seizures. These patients most likely are on medications to
yes,
control their
yes,
seizures,
Jay.
and they're
So
getting
there is
breakthrough
a
seizures.
chance, yeah, SUDEP
Yeah,
could occur in your dental office.
exactly,
Very important.
or just a seizure, an epileptic seizure, and
Correct.
so most of the time, patients will know the seizure is coming on either a couple minutes or a few seconds before it comes on. They'll have what's called an aura, and it could be a strange taste or a smell, or they may see
Right.
something, or just a funny feeling that they know the seizure is coming on because it happens every time. And so, if you do have a patient that suffers a seizure within your patient, the most important thing is to just make sure that they stay safe. The seizure generally will only
Protect the
last
patient.
a minute. Rarely does it last longer. In fact, if it lasts up to 5 minutes, you're calling 911.
Absolutely.
But if they have a seizure that lasts less than that, you just want to keep the patient safe.
Yes.
And so if they're in the dental chair,
One
you don't
person
want
on
to,
each side of the chair. That's
yeah,
right.
so they can't roll off. Don't
They
put
can't roll
anything in their
off.
mouth. Don't put it
No,
because
and
they're going to
don't
clamp
try to
down.
get inside their mouth.
Yeah,
No, no.
yeah, not at all. And just especially protect their head from injury.
All right, Jay,
Um,
next drug.
Okay. And another thing you do is to loosen their clothing too, and just
That's right.
stay with them until the seizure ends. Okay, so the next drug is Camzyos or mavacamten.
Great name there, huh?
Yeah,
Mavacamten. All right. And it's for
Camzyos I think is
hypertrophic
easier to say.
cardiomyopathy.
Yeah,
All right. And you know, Jay, there are two types of cardiomyopathy, as we see, hypertrophic as well as dilated.
right,
And you know, this drug is there to improve the functional capacity and symptoms associated with cardiomyopathy.
right.
And of course, this is something that if a patient comes in on this drug, you have one of those medically compromised patients. All right.
Right. Because what happens in hypertrophic cardiomyopathy is the ventricular walls thicken.
Yes.
The cells, the muscle cells hypertrophy. And so what that does is it makes the wall thicker and stiffer. And as a result, the left ventricle can't pump out. The ejection fraction is decreased, and
Yes.
you end up getting backup of blood in the system because the right atrium. I'm sorry. The left. Did I say right? I didn't say left. I've been meaning left. Sorry.
Left.
So the left ventricle can't pump as efficiently. Neither can the right, but the left is the one that is more important as far as just overall issues. But the atria can't get the blood to flow into the hypertrophic ventricles because they're just not filling. And so
No.
these patients a lot of times will have heart failure and are at increased risk of MI or stroke.
And you know, they also have the increased risk of sudden death in your office due to the electrical changes associated with this as well, too, Jay. And so,
Yeah.
you know, how is this treated? Your patients are going to be on a blood thinner. They're going to be on a heart medication as well, too. And what we mean by that is an antiarrhythmic medication. Okay. We're going to be on an antihypertensive medicine. So now here we go. We're starting to stack those medicines again. And, you know, I always like the Roberson rule of threes. 3 medications on one disease state could easily send up a red flag to you right there as well, too. And I always like to use the term out there. Is this patient medically capable in my office, medically compromised, or medically fragile? This is going to be a fragile patient in your office. Okay.
Absolutely.
And you've got to be careful how you're treating him. And you may want to limit the amount of treatment you're doing to this patient, but you are going to talk to that cardiologist before you say, yeah, let's just charge right on in there and start treating this patient.
Right. Exactly. And you notice on the slide that this Camzyos is a first-in-class cardiac myosin inhibitor. And basically what it does is it reduces the number of myosin actin bridges that form and causes the cardiac muscle to relax, and as a result increases or rather reduces the left ventricular outflow obstruction that's caused by the hypertrophic muscle. So it improves cardiac filling pressures and cardiac output.
And, like you talked about, they could also have congestive heart failure from this. And, we talked about this last year as well. And I'm sure we'll go back into it. We'll talk about the 4 classes of congestive heart failure, stage A, B, C, and D. And the lower we go in the letters, the higher the risk the patient is in your office. Again, we're trying to help you in preventing a medical emergency or a life-threatening emergency that could either be career defining or career ending for you.
Yeah. And this drug is metabolized through the cytochrome P450 system in the liver. And
That's
so you've got to be careful prescribing any drugs that affect cytochrome P450, such as erythromycin.
Yeah.
Which is a strong inhibitor, which will increase the blood level of this drug in the patient's bloodstream, and can put them at toxic levels from drug overdose, from having too much Camzyos in their system.
Okay, let's go to our next one.
Okay,
great discussion right there.
Okay, so I think we've gone through hypertrophic cardiomyopathy. The next one, is QUVIVIQ. I like that name too.
I do for insomnia. All right.
Yeah. So this is a dual orexin receptor antagonist, or DORA, for treating on insomnia. What orexin is a hormone that plays a role in wakefulness, and so by inhibiting, by being an antagonist to the orexin receptors, what this does is it suppresses that wake drive to allow the patient to go to sleep.
That's right.
Yeah, but we've got
other drugs from the past on this as well, Jay. You talk about drugs like Ambien, Bolsamra. In fact, we talked about Dayvigo last year as well too.
Yeah. So those are all orexin receptor antagonists also.
So if you've got insomnia, guess what? You're going to be tired. All right, you're going to be exhausted, and look at how many fatalities and motor vehicle accidents and so forth are due to insomnia.
Yeah, exactly. And drugs like Ambien are GABA receptor up modulators, and trazodone is a serotonin up modulator. So those work through different mechanisms. So what we need to keep in mind with these drugs is they're all in themselves, whether we're talking about Ambien, trazodone, or one of the orexin antagonists, is they're all CNS depressants. So you've got to be very careful about any other CNS depressant that could have an additive or a synergistic effect with this drug. And so if you're prescribing narcotic opioid post-op pain medications, or if you're sedating the patient, if you're going to give the patient oral oral Valium to take, or anything to sedate them, this can act along with this type of sleep aid drug for insomnia that can make them very depressed and cause respiratory depression. And
so
if you don't identify that, that can of course lead to cardiac suppression if the patient's not breathing.
Just so much we got to know, don't we, Jay? Huh?
Yeah.
I mean, so many little fine details. Because the bottom line is we don't want an adverse drug reaction.
Right. Exactly. So we need to know what these drugs are and how they interact with drugs that we may be giving the patient, and any effects those drugs may have on our treatment, such as having a patient on a blood thinner, knowing how to manage their blood thinner for the procedure you're doing. All right. So let's go on to our last drug, which is Rebiota. And this is an interesting drug because what it is basically live fecal bacteria, microbiota that is basically mimics a normal, healthy colon microbiota environment. And so this is not a drug that is used to treat C. difficile diarrhea, but it's used to treat recurrent C. diff occurrences. And of course,
so Jay, the critical thing right there is about the recurrence. Okay, so first of all, as dentists, what are we labeled a lot of times? Overriding antibiotics,
Yeah.
correct?
Yeah.
All right.
And, basically any antibiotic that you give the patient can alter the intestinal flora, small
Correct.
intestine, large intestine. But there
Any can
are,
be a culprit for causing C.
yeah,
diff infections.
but
That's
there are
right.
some that are more frequent culprits. And the big one is clindamycin.
Which
And
was
that's,
taken off of the AHA guidelines for SBE prophylaxis.
yeah, just for that reason. And
Yeah.
so, if a patient does develop antibiotic, and you want to counsel your patients, especially when you give them clindamycin, but also if you give them penicillin or any antibiotic, that if they start getting diarrhea, okay, and not only just regular run of the mill diarrhea, but if it's foul smelling, if there's bleeding,
Yes.
if they're having diarrhea 3-4 times in a day and it's going on more than one day, to let you know right away, because these are all signs and symptoms of a C. diff infection. And C. diff infections are much more than antibiotic induced diarrhea. This can be deadly, especially in older patients.
Yeah, because PMC, pseudomembranous colitis.
Right.
The other thing too is AAC, antibiotic associated colitis, where they're starting to have cramping in their stomach and all that. So this is very important. You talk to the person you give or their escort. Hey, here's some things to look for that you need to give me a call, because Jay, there's about 500,000 C. diff infections every year in America alone. Okay,
Yeah.
and then the issue is anywhere from 1 to 6 will have a recurrent C. diff infection.
Yeah.
All right. And then the concern of that, and why this drug Ribota is so great, is that 1 in 11 people over the age of 65 will die from a C. diff infection.
Right. Yeah. So this is given to prevent recurrent infections.
That's right. This could be all due to the antibiotic that you prescribed.
Yeah. And of course, the way that this is treated is with antibiotics. And the antibiotic that is used most frequently, if it's mild, is oral metronidazole.
Yes.
But if it's severe, IV vancomycin.
Right. And then they got another drug too, Jay, Dificid, DIFICID, and that's used orally for 10 days as well too.
What type of drug is that?
Well, that is another type of fidaxomicin. All right.
Okay, so it's another antibiotic.
It's another antibiotic. Okay. So it's used for this initial treatment as well too.
Okay.
And ask any physician. C. diff can be a bear to handle because it's brutal on your patients.
Oh yeah, I've had patients that I've seen that had C. diff from a prior antibiotic regimen, and they were miserable. And some of them came close to death. They're in the hospital for a month.
Again, you bring up a great point, Jay. So in that health history, when we're talking to the patient, they talk about allergies and all that. Well, I really didn't have an allergy to this drug, but it really did tear up my stomach. Red flag. Ask further. What do you mean by tearing up your stomach? Were you hospitalized for that? Yes. Well, then you're going to need to probably talk to their gastroenterologist. Say, hey, what can I prescribe? And document. Okay. So everything we've talked about tonight, Jay, and to our listeners, if you talk to a physician, whatever specialist or specialty field they're in, document.
Exactly.
I can't say that enough. Okay.
Yeah. And now with electronic medical records, the one thing I like about, I hate having to type because I'm a very slow typist.
Yes.
But the one thing I like is that, let's say I get a call at home on the weekend or at night, I can log into my electronic medical record at the office and write a note.
Right.
Whereas before I'd have to write myself a sticky note to remind myself when I got to the office to put something in the patient's chart.
Yes.
So it's much easier to, if you have an electronic medical record, most of us do by now, that you document as soon as you have that conversation, no matter where you are, if you get the call from home or in the office, just get it in the system. Now, there's another drug that's also used for recurrent pseudomembranous or recurrent Clostridium difficile infection, but it's used in conjunction with antibiotics, and that's Zinplava or bezlotumab, which, as you can tell from the name, is a monoclonal antibody. And what this does is it neutralizes the effect of the Clostridium difficile toxin B. So it doesn't kill the bacteria, but it neutralizes the toxin. So this is another drug that a lot of times is given to patients that develop C. diff, in addition to the antibiotic that is used to knock out the infection. And then they'll be given Rebiota to restore the normal flora in the gut, to hopefully prevent another recurrence.
Right.
Yeah. All right. So, okay. So I guess we've been talking for almost 50 minutes, and we're going to try to finish in an hour.
But Jay, one other thing I want to mention to the audience, now that we've wrapped up a brief synopsis of 2022, we talked about this early in our talk tonight. How do you keep up with everything?
Yeah.
And we're so excited. Coming very soon, audience, to dentallearning.net will be your solution to all of this. It's called PharmaDent.
Exactly.
And Jay and I recognize the fact that you don't have time to really leave your office to go hear a lecture maybe for 1 or 2 hours, and that topic might be on a very small little scale, and you didn't get that great of a pharmacological update. And then the sad thing about a lecture, usually you forget most of it in a day, right, Jay? Wouldn't you agree?
Yeah. Oh, yeah. Yeah.
So now you left your office and you went and heard something briefly. What tidbits did you pick up? Yeah. Well, Jay and I have solved that problem with PharmaDent through dentallearning.net. It's going to be 15 modules. We've got all kinds of medication classifications.
Yeah. It's about 2 hours per module. So you got 30 hours of CE. And you can go back and watch it as much as you want. So if you want to, it's been 6 months since you did that particular course, you can go back and do it again.
Oh, that's such a great point, Jace, because it being web-based, you can go back and read or re-see antihypertensive, blood thinners, antiarrhythmics, anti-diabetic drugs. We're going to have a section on emergency drugs. We got a section on opioids and analgesics, bisphosphonates. Then we even went further and created like drug-to-drug reactions. Mm-hmm. And then I love the section, Jay, on I'm on this, but the doctor prescribed me that. What kind of interaction could occur there?
Exactly. As well? Drug interactions are really important to know about. And again, with some of our electronic prescribing, and you put in the patient's medications that are on, you'll get a warning popping up that there's an interaction, which is great.
Well, and then on top of that, Jay, we're going to take it a step further. When you sign up for PharmaDent, at the end of each month, you'll get what's called the new medication alert for dentistry document. And whatever new drug came out that month, Dental Learning is going to send it to you. And then you're going to have a list of questions that you could ask your patient that when they come in, that they're on these various medications that Jay and I have created. Mm-hmm. Exactly. So again, you're getting pharmacology from two men who are in the trenches that know dentistry just like you. Yeah. All right. So, and the great thing about this, there's no leaving your office. There's no registration fee at another city. There's no hotel. There's no airline ticket. And you know what airline flying is like right now.
Yeah, not fun.
It's not fun. This is going to solve everything for you. And then if you're a subscriber to PharmaDent, at the end of our PharmaDocs show, you're going to get a chance for a CE quiz and you get another hour for that. So dentallearning.net is taking care of you when it comes to pharmacology. And Jay and I have already thought about new topics to create as well. And we invite you to let us know, are there any other topics in pharmacology you want to know? Exactly. Because like herbal medications, immunosuppressants, so many other topics we can talk about, and we will be adding more and more to it.
Yeah, because we're doing this for you. All right, so let's talk about our two medical emergencies. And I'm going to get rid of us and make this a little bit bigger because it's hard to see.
So Jay, the reason why, this is something new we're doing each month on PharmaDocs. We're going to have a surprise medical emergency. Jay and I are going to go through it, and we're going to help guide you through what you need to do when that patient comes in your office, and should they have that type of medical emergency.
Right.
So
Yeah.
you're getting pharmacology, you're getting medically compromised patients, you're getting adverse drug reactions, you're getting medical and sedation emergencies. Where else could you get that?
I don't know. Where else? I don't think anywhere, John.
dentallearning.net.
Okay.
No, Jay, this is a brand new concept. I love it.
Oh, yeah. Yep, definitely.
Okay, so let's talk
We've been
about
working on it for
anaphylaxis.
quite a while. All right, so
Correct.
well, let's start with allergic reactions,
Yes.
because these are uncommon but common. And so, how do you know if a patient's having an allergic reaction to a medication that you gave them? Well, of course, they're going to have some redness, maybe a little bit of a rash, hives,
or itching.
Exactly. And so the first thing you're going to do is stop what you're doing and stop giving them whatever drug you're giving. If you're injecting IV sedation medication, if you're giving them local anesthetic, just stop right then and there.
And get them in the correct position.
Yep. So what happens is you want to be prepared. Well, actually, even with an allergic reaction, and then what we're going to talk about, anaphylaxis, you get basically a dilation of the arterioles, and basically the blood pressure drops. And so what you want to do by placing the patient in a supine position with their heart, legs above their heart, is it keeps as much blood as possible in the central circulation rather than going to the extremities, because that's where it's needed.
And then, of course, our drug of choice for allergic reaction, we all learned this in dental school, is diphenhydramine.
Yep, or Benadryl, exactly.
Or Benadryl.
Yeah, and you should have this in your office in an injectable form, so you can give it either IM or IV, because when you need to give it, you need to give it quickly, so that an allergic reaction doesn't progress on to an anaphylactic reaction. And it doesn't just stop there. If the patient does have an allergic reaction, of course, you want to note that in the patient's chart, have them let their physician know, or you call their physician and let them know. And then you want to follow it up with some diphenhydramine orally, like 25 to 50 milligrams every 6 hours for the next 2 days. Usually the 25 is sufficient. 50 may make them very sleepy. So if they can tolerate 50, great, but if not, 25. And of course, what's interesting is that, there are patients that are actually allergic to diphenhydramine.
Oh, correct.
Yeah. They're allergic to the thing you give them for an allergic reaction. Figure that one out.
I know.
If you figure that one out, you'll get the Nobel Prize.
And one tidbit I'd like to also offer you, make sure you call that patient that night and check on them, and document it in the chart as well too. Yeah. So we're wrapping up allergic reactions, and then we go down to the last signs and symptom, Jay, that was angioedema. So one thing I want to differentiate to the audience, and one thing I preach to my audience when I'm lecturing on this topic: allergic reaction will be a mild case, would be rash and an itch, Jay. Mm-hmm. But then a major is going to be angioedema, urticaria leading into anaphylaxis. So if that patient is having a major urticaria or angioedema in your office, get ready. There's very good chance you're on your way to treating an anaphylactic reaction in your office.
Get ready. It's coming. So exactly.
And that's the last thing you thought would happen in your office that day. But you got to be prepared, because we must lose that, quote, it's rare mentality. Mm-hmm. Medical emergencies are not rare. And there's about 24 of them. As a general dentist or a practicing dentist, you must be highly trained to handle all of them.
Yeah. I mean, they're in general rare, but when they happen in your office, it's a whole different matter. You got to know.
If you treat your training or preparation as rare, then it's probably going to be a catastrophic result in your office.
You got to be up on these all the time. Exactly.
Yes.
Exactly. And
so here we are, Jay, at anaphylaxis. Okay, so now we do have that patient in anaphylaxis.
Yeah, so these are patients, they're going to start wheezing because they're going to have airway constriction. They may have stridor, which is kind of again, just like a loud pitch wheezing sound. Yes. They may have swelling of the tongue and throat, which could compromise their airway. They may have increase elevated heart rate, or even a dysrhythmia, or their blood pressure may drop because of the peripheral dilation, and this can lead to a cardiac arrest. So when you suspect they're going from an allergic reaction to anaphylaxis, you've got to act fast. So you should have that emergency kit there with all the drugs you need ready to go. And of course, the first thing you're going to do, if they're not already in a supine position with their legs elevated, is get them in that position and then do your BLS survey. Airway, breathing, circulation. Are they, is their airway open? Are they breathing? Okay. And do they have a pulse? And if not, you're going to start basic life support. But the next thing you're going to get them on some oxygen, and you're going to give them the drug that you give for an anaphylactic reaction, which is
epinephrine. And there's absolutely no contraindication to this, Jay.
Right, exactly.
Epinephrine is the life-saving drug right here.
Yeah, absolutely.
And then, of course, you can follow the rest of the algorithm: hydrocortisone or Decadron, Benadryl. Jay, in my lectures, I call it the dead medications.
Yeah.
Diphenhydramine, epinephrine, albuterol, and Decadron. Yeah. Those are 4 drugs you want to give a patient have an anaphylactic reaction, because if you don't, you may have a dead patient.
Yeah.
Okay.
And if they're not getting better after the first dose of epinephrine, after a couple of minutes, give them another one.
Well, Jay, studies show 38%. You have to give another dose of epinephrine as well too.
Yeah, because again, this is a drug that's not going to hurt them, and it wears off quickly, like a couple of minutes.
And please, when you go to the top of the algorithm, call 911.
Oh yeah.
Don't sit on this and think, okay, this is, because you're going to be in a state of shock. You're going to be in a state of denial. This is not happening, because
don't think you can handle this by yourself. This patient is going to need to go to the hospital.
And with your BLS, next time you get your training there, ask to learn how to insert an LMA, because this might be the difference in life and death in your office. And Jay, when
that's a laryngeal mask airway.
Yes.
For those of you who don't know the abbreviation.
You're not going to be able to intubate this patient. Jay, you and I probably couldn't intubate this patient, because when they start to swell like that, that's it. But an LMA, we can get that down and ventilate for this patient and breathe for this patient. Okay. And it's even important when you tell your front desk personnel, who I call Rover in the emergency response plan, that they need to tell 911, we have an anaphylactic reaction going on in Dr. Reznick's office. Please hurry. All right. Yeah. Now you're listed basically as an alpha trauma, but you're top of the pecking order. They're trying to get to your office. But Jay, this emergency is of 3 emergencies that I talk about: anaphylactic, sudden cardiac arrest, and foreign body obstruction. You got about 3 minutes to do your job, or you have a dead patient.
Exactly.
Ask yourself to, after you go through our lecture today, go back into your office. How would myself and my staff handle anaphylaxis, sudden cardiac arrest, or a foreign body obstruction? All right. Because it's happened in dental offices. It will continue to happen in dental offices.
Yep. It's going to, until, forever.
Jay, could you go back to the algorithm for me?
Oh, okay.
I do want to read something. I want to read that disclaimer. Okay. This chart is to be used as a guideline. It does not guarantee to prevent an unfavorable outcome, result, or death. Practitioner may choose to deviate from the algorithms based on their clinical experience, training, and factors unique to that individual. All right. Thank you, Jay.
Okay. All right. Let me go on to the next one. And here we are again.
So coming very soon is PharmaDent. You've already heard the description. Jay and I are very excited. We have solved a problem. We have created a solution for the dental profession. You're going to be continually updated on pharmacology. And we just look forward to every month doing PharmaDocs and helping our fellow practitioners become best practices at everything they do here.
Absolutely. Our next episode is going to be, and again, we're on Pharma Friday, the second Friday of each month. So next month, that'll be February 10th, again at 5 p.m. Pacific time, which is 7 p.m. where John is, and 8 p.m. on the East Coast. And again, and our format is going to be talking about new drugs that have been approved by the FDA in the past month, as well as covering a medical emergency of the month.
That's correct. Thank you all for attending.
All right. Have a good night, everybody, and we will see you next month.